Good evening, friends. This is Dr. Sandeep Dewan. I'm a critical care specialist, and today we have with us Dr. Sahil Popli. He is the managing director of CMC Hospital SR and also head of intensive care unit at CMC Hospital. Welcome, Dr. Sahil Popli, to our FB live session.
Uh, Thanks a lot, sir. It's my great pleasure to be here, sir.
Thank you, Dr. Sahil. So today the topic that we are going to discuss with Dr. Sahil is the poisoning scenario in our country, and particularly in the region which Dr. Sahil is practicing as the in charge of the ICU. So, Dr. Sahil, the first question which comes to our mind is, uh,
Mhm.
what kind of poisonings you see in your day-to-day practice when you are in the ICU, particularly in the emergency and the ICUs?
So there are two sets of patients which come mostly from, if we see the city patients, the most common poisoning is the sulfose poisoning or the rat poisoning. There are two category of these patients. And from villages, the poisoning which comes is more of a organophosphate, monophosphate, or again sulfose is again common in the village patients also. So we see a lot of sulfose, lot of organophosphates, and these rat poisons which come a lot. Sir.
Okay. Now, is there a particular time in the year which you see more poisonings, or you see less, or it is all throughout the year you have the same number of poisoning patients
No,
coming
no,
to your
sir.
hospital?
There is definite increase in the poisoning in the season just after the monsoons, before the festivities. Once there is this cutting season and there is a lot of movement in the villages, we definitely see an increase in the poisoning at that level. Initially, also when we started our practice, we used to see during the result times also, but that trend has faded away over a period of years now. We see more of poisonings during this time frame when the monsoons get over and the festive seasons are just starting.
So, any specific reasons why this is the time frame when you see more poisoning? Any literature? Have you ever tried to analyze this situation?
Sir, my wife is a psychiatrist, so I get to know these patients little closely. So,
Okay.
what we could interpret out of it is what is the maximum duration of the manic phase and the depressive phase comes in the May and June period. The maximum psychiatric illness gets a boost on that period, and there are relapses in these patients. And these relapses, if not controlled by proper medication or counseling, or if they don't, they'll end up in these kind of situations where the suicide comes into the picture, poisoning comes into the picture. So it actually correlates with the trend when the psychiatric patients have their relapses and this poisoning comes, rather than following a trend of cutting season or stress for students. It usually follows these trends, which I believe. And she has actually published a paper around 3 years back, and which should be published around in next year, Indian Society of Psychiatry, which substantiates our data.
Great, great. It is actually very, very heartening and actually a big learning for us that there are seasonal variations and there is a particular time of the year when you see more poisoning. Dr. Sahil, coming to my
It is.
next question, which is actually very relevant for common man. You are a critical care physician. You run a hospital. What emergencies can in an emergency, what can a common man do till he reaches your hospitals? Is there anything that, let's say, the layman, he sees somebody who has just consumed uh, or any poison, because the layman would not know herbicide or insecticide. Is there anything that they can do while they are on their way to the hospital, so that they can save their near one's lives?
What I believe the most important thing which has to go away is this induced vomiting concept of, whenever they see a poisoning, they try to induce vomiting rather than, rushing to the hospital. They waste a lot of time, inducing things, trying to get things like, eggs and whatever it is, and they don't even look at what is the stage of poisoning and how critical the patient is. They just waste the time. My sincere suggestion would be as soon as they identify the poisoning, they should make the patient lie in a left lateral position, so that the secretions whichever there in the mouth don't go into the respiratory tract. and they should reach a hospital care facility, whichever is nearby, as soon as possible, so that a proper lavage, that is the washing off the poison from the stomach, can be done, and they can be referred to appropriate center if required. So rather than wasting time in inducing vomiting and doing those desi totkas, it's better to rush to a healthcare facility which it can be managed in a proper way.
No, very rightly and aptly said, Dr. Sahil. It is people waste a lot of time during emergencies. I think even I feel they should go. Most of these patients would need ICU monitoring, even if there are mild poisonings, at least for minimum
Right.
24 hours. So any
Minimum, yes.
poison should be taken very seriously, and one should actually rush to a hospital which is equipped to manage with these kind of critical situations.
That's absolutely
Now,
right,
what
sir.
I'm sometimes I will just like you to explain more detail about left lateral position, क्योंकि वो थोड़ा medical term है. Maybe हमारे कुछ
हाँ जी सर.
community में लोग इसको बेहतर समझ पाएंगे. If you can explain a bit more details.
हाँ सर, इसके अंदर लेफ्ट लेटरल पोजीशन के अंदर जो द ओनली थिंग इज वी हैव टू टेक केयर आवर शोल्डर शुड बी द लेफ्ट शोल्डर should be below one, and the patient is tilted so that its chest is almost perpendicular to the bed. जिसको पासा लेना कहते हैं सर, पासा लें, उनका जो बायां कंधा हो वो उसको नीचे रखें और दायां कंधा ऊपर हो, एंड दैट दिस पोजीशन शुड बी मेंटेन्ड टिल दे रीच द हेल्थ केयर फैसिलिटी. एंड इसको बनाए रखना है टिल मे बी 5 मिनट्स, 10 मिनट्स, मे बी 1 आवर, सो दैट कि वो सिक्रीशंस बाहर आती रहें सर. So it is basically tilting the patient on his shoulder so that the body is perpendicular to the bed or the surface which they are dealing with, sir.
एक और जो बड़ी कॉमन प्रॉब्लम देखी गई है, पेशेंट सबसे पहले जैसे आपके हॉस्पिटल नहीं पहुंच पाता, बड़े सेंटर नहीं पहुंचता, वो किसी जनरल फिजिशियन के पास जनरली ले जाते हैं. तो क्या हमारे जीपीज के लिए भी ये गाइडेंस तो जरूरी है ही ऑब्वियसली. क्या वो कुछ और
हाँ
एक्स्ट्रा
जी.
कर सकते हैं जीपीज, जिससे कि
हाँ, बिल्कुल
इमीडिएटली
कर सकते हैं.
पॉइजन का इफेक्ट
बिल्कुल
कम
कर
किया जा
सकते हैं
सके?
सर. व्हाट मैं फील कि जो हमारे जीपीज हैं, जो दो गलत चीजें वो बहुत ज्यादा करते हैं. एक तो एसिडिक पॉइजनिंग के अंदर सबसे पहले राइल्स ट्यूब या लवाज करने की कोशिश करते हैं कि जस्ट एक नेचर ऑफ पॉइजनिंग असर्टन हो जाए कि वो एसिडिक नहीं है, सो देन वी कैन प्रोसीड. और सेकंड, गैस्ट्रिक लवाज सर बहुत ज्यादा हाई वॉल्यूम से होता है, 4 लीटर्स, 6 लीटर्स, 8 लीटर्स. दैट दैट इज नॉट एक्चुअली रिक्वायर्ड इतना ज्यादा, और एस्पिरेशन रिस्क बहुत ज्यादा बढ़ जाता है सर. सेकेंडली, जो आइडेंटिफाई चीजें नहीं होती, बेसिकली दे डोंट गो फॉर द रिदम, और बीपी को स्टेबलाइज करने से पहले गैस्ट्रिक लवाज की तरफ भागा जाता है सर. सो आई रियली रिक्वेस्ट माय जनरल प्रैक्टिशनर, माय फ्रेंड्स, माय कोलीग्स टू प्लीज सिक्योर अ large bore IV line, start the fluids, manage the things, and then we can, after 5 minutes, we can plan the lavage. And once the airway and the circulation are protected, it's easier for us to do the things and manage the patient better. And a timely referral for the patient is utmost important. Basically our without an ABG, without blood parameters, we cannot manage even a simple poisoning also. So I would request my general physician, okay, as soon as this patient is stabilized, will please shift to a center where all the facilities are available, and don't do with high volume lavages. Simple 500 ml, 1000 ml should be fine with it.
यस, आई एग्री, बिकॉज इतना स्टमक का कैपेसिटी नहीं होता है कि आप
हाँ जी.
4 लीटर का लेवाज दे पाए. तो ऑब्वियसली एस्पिरेट तो वो होगा ही. सो इसलिए अब लिटरेचर भी जो है वो 1 लीटर से ज्यादा लेवाज का रिकमेंडेशन नहीं करता. वेरी एप्टली सेड डॉक्टर साहिल. अनदर क्वेश्चन व्हिच कम्स टू माइंड नाउ, ऑब्वियसली अगर हम पेशेंट का जर्नी देखें, तो अब सपोज पेशेंट लैंड्स अप इन योर हॉस्पिटल आफ्टर प्रॉपर मे बी मैनेजमेंट बाय जीपी. So even in morning and night, I'm sure CMC hospitals has the capability to manage any kind of poison. या ऐसा कुछ पॉइजन भी है जो जो आपको लगता है कि नहीं, ये ऐसे पॉइजन जो इस बेल्ट में मैनेज नहीं हो सकते?
Sir, apart
आई
from ECMO
थिंक
facilities, which are in vogue for sulfose poisoning, which require referral, we can manage most of the things in our hospital. Timely for ECMO, we really identified the patients, and since it's a good thing that we have the tie-up with the eNext ICUs, and we get the patient screened by them that whether this patient will benefit from ECMO or not, so that we can shift the patient to a ECMO facility. So this is, one good thing with our team and our associate eNext ICU teams, so that you get a proper guidance where the people are actually doing ECMO. They can see the patient, they can actually talk to the relatives, they can talk about the cost, talk about the benefits, and if required, you can timely shift the patient. So in that case also, if a patient of sulfose poisoning, or if he is an ideal candidate for ECMO, we get it screened at our center only before shifting, so that the hassles of timely receiving the ECMO or the coordination with the team is not hampered, and the patient gets the adequate treatment at appropriate time.
बिल्कुल डॉक्टर साहिल, आई थिंक आप इज आपका सेंटर इज वन ऑफ द मेजर पॉइजन सेंटर्स. अभी लास्ट वीक एक सल्फाज आपने सक्सेसफुली मैनेज किया है,
Sir.
और इसका इजेक्शन फ्रैक्शन 15% तक चला गया था.
Sir.
और एक और पॉइजन जो मैंने बड़ी कॉमनली देखी है आपके हॉस्पिटल में, या आपने भी देखी होगी, इस पैराक्वेट, जो कि इस
Paraquat, yes.
बेल्ट में काफी कॉमन है. क्या
काफी
पैराक्वेट
common.
में और बाकी सल्फार्स या ऑर्गेनोफॉस्फरस में कुछ अलग डिफरेंस आप एडवाइस करेंगे अपने जीपी फ्रेंड्स को, या मोर और लेस उनको अपना मैनेजमेंट सेम रखना है और जनरल जनरल पॉइजन मैनेजमेंट सेम रहना चाहिए?
जनरल पॉइजन मैनेजमेंट तो सेम रहेगा सर. द ओनली रिक्वेस्ट की पैराक्वेट है तो अर्ली हीमोफिल्ट्रेशन इज गॉट सम रोल, अर्ली साइक्लोफॉस्फेमाइड हैज गॉट सम रोल, सो दैट कि 6 आवर्स के अंदर वो पेशेंट सेंटर पे पहुंच जाए, तो इट माइट बेनिफिट फ्रॉम हीमोफिल्ट्रेशन. वी रियली डोंट नो हाउ मच हीमोफिल्ट्रेशन actually helps our patient, but this is worth trying, especially in those 23% or 18% paraquats with large volume injections. Yeah, definitely this hemofiltration is the only way through, I believe.
बिल्कुल, और मैंने देखा है आप बड़े अग्रेसिवली हीमोफिल्ट्रेशन करते हैं और आउटकम्स भी आते हैं, क्योंकि लिटरेचर भी कहता है कि अगर आप 4 घंटे में हीमोफिल्ट्रेशन कर दें तो 50% पैराक्वाइट का लोड बॉडी में कम हो जाता है,
कम हो जाए, कम
और
हो
विद इन
जाए.
24 आवर्स एक और कर दें सेशन तो वो और
हाँ,
कम किया जा सकता है. सो आई थिंक
since
दैट वे पीएमसी इज डूइंग
associated with this eNext ICUs and all that, getting the latest protocol from the eNext ICU from your team also, it boosts our confidence कि we are giving this our state of art facility to our patients, and we are not lagging behind in any field at all. So,
माय लास्ट क्वेश्चन डॉक्टर साहिल, आप जनरल कम्युनिटी में अपने एरिया में अपने रीजन में लोगों को क्या एडवाइस देना चाहेंगे एज अ क्रिटिकल केयर स्पेशलिस्ट स्पेशली रिलेटेड टू पॉइजनिंग?
सर, मैं एज अ क्रिटिकल केयर स्पेशलिस्ट नहीं, एज अ जनरल प्रैक्टिशनर डॉक्टर, मैं कह रहा हूँ these poisonings don't occur overnight. There are precipitating factors which are going on around them for many days. Please identify these, and the best way to solve the poisoning is a day before that. So I'm this is not the platform to discuss the psychological issues, but I really मैं आई वुड लाइक पीपल की जो आसपास चल रहा है, प्लीज उसको आइडेंटिफाई करें, आइडेंटिफाई ट्रिगर्स, एंड वी हैव टू प्रिवेंट ऑल दिस सुसाइड, बिकॉज ऑल दीज आर यंग पीपल, these are not old comorbid people की जिनकी लाइफ स्पैन नहीं है ज्यादा. And this has to be dealt, especially in our belt where this comes as a stigma. People don't try to talk about it कि कोई पहले की पॉइजनिंग की हिस्ट्री भी है, they try to hide it कि पहले पता ना लग जाए कि पहले कभी हुआ है ऐसा. And and अगर होता है ऐसा तो डोंट पैनिक, रश टू अ हेल्थ केयर फैसिलिटी, डोंट डू देसी टोटकास, डोंट गो फॉर मंदिर झाड़ास, डोंट गो, मतलब आज की डेट में हमारे पास मोस्टली सारे पॉइजनिंग का कहीं ना कहीं एक ब्रेक थ्रू है कि हम हेल्प कर सकते हैं पेशेंट की. तो एज सुन एज यू आइडेंटिफाई अ प्रॉब्लम, उसकी उल्टी उल्टी कराने की कोशिश ना करें. प्लीज रीच टू अ हेल्थ केयर फैसिलिटी where you can actually get a good care, even smallest possible around the hospital in around Hisar is capable for all the basic cares which is required, and timely referral is there. Most of the doctors appreciate this thing ki patient require good care and they are referred to the appropriate center. So my clear cut message is identify the triggers, please try to stop this, and if not, please don't panic, and get the best healthcare facility nearest possible wherever is available.
I completely agree with you, Dr. Sahil. I think identifying the triggers is very important. और अगर ट्रिगर मिल जाए तो साइकोलॉजिकल काउंसलिंग शुड बी डन अर्ली सो
Should
दैट
be
वी
done,
कैन
sir.
प्रिवेंट दीस सुसाइड्स.
Sir,
With that, yes, sir, please.
सर
Yes, Dr.
रिकरेंट
Sahil, please.
सुसाइड, रिकरेंट सुसाइड अटेम्प्ट भी बहुत ज्यादा हैं सर. तो इवन इफ वी आइडेंटिफाइड द फर्स्ट स्टेप और वो सेवेबल है, तो सर वी कैन डू अ लॉट ऑफ थिंग्स सर.
No, I agree. So, Dr. Sahil, thank you very much on discussing a very important topic on
Thank
FP
you,
Live
sir.
with us.
Thank you, sir.
We will thank you, friends, for joining. We'll be coming back again with a new topic, maybe with Dr. Sahil Popli again. Thank you, sir, for joining with us.
Thank you. Thank you so much, sir. Thank you, sir.
Thank you very much.